Good evening, everybody. Thank you for joining me. My name is Kevin Mott, and on behalf of Black Health Matters, NephCure.org, Travere Therapeutics, and Kappa Alpha Psi Fraternity, I want to welcome you this evening to our discussion on FSGS, Diagnostics, Signs, and Symptoms. Tonight, we're going to hear from two very accomplished, very highly qualified professionals to give us information about FSGS, which is a form of a chronic kidney disease that disproportionately affects African Americans. Want to let you know that one, Black Health Matters does a lot of work in terms of education, and this is just the first of three conversations we will be having about FSGS, bringing in experts. And we're working, like I said, in conjunction with Kappa Alpha Psi and their Healthy Kappas, Healthy Communities initiative. So I'm actually here wearing three different hats tonight. One, I am a board member of NephCure.org. Two, I am a member of Kappa Alpha Psi Fraternity and the Evanston Alumni Chapter here in the North Central Province. And three, I am actually an FSGS patient. And before I get to the doctors, I want to tell you a little bit about my journey and my story with FSGS. So in 2002, I was dealing with migraines, and it's something I had before, but they seemed to be really consistent. And I decided to go to a doctor. And I go to this doctor, and we discover, hey, your blood pressure extremely high, and we have to get your blood pressure under control. So the doctors, he gave me various blood pressure medications. We tried a couple of things, and none of them seemed to work. And at one point, the doctor said to me, Kevin, none of this is going to work unless you eat less fried food and canned goods. And that kind of caught me by surprise, because I had never said anything to him about that being my diet. We had never really discussed my diet. And to be perfectly honest, we had never really had a conversation about me. So I decided that maybe this doctor had some bias, and I didn't necessarily want to deal with it. So I left and went to a new doctor, and same thing happened at the new doctor. Your blood pressure is very high. We have to get your blood pressure under control. And we tried different drugs, and nothing worked. And surprisingly, this doctor said to me, even if it was a long time ago, if you use cocaine and things like that, this is going to affect the performance of these drugs. Once again, we had never had any type of discussion about my lifestyle, my habits, or vices, or anything. So I was very shocked when he said that, and I said to myself again, I guess I'm dealing with somebody's biases. So I want to go ahead and move on to another doctor. I went to another doctor, and the same thing happened. Your blood pressure is high. We have to get it under control. We're not able to get it under control. And Kevin, if you are using steroids or HGH or anything like that, that is going to affect these drugs. And at the time, I was somebody who worked out a lot, but it wasn't like I was The Rock or anyone like that. So once again, I kind of felt that I was dealing with doctors who were not talking to me or listening to me better. It's a better way to put it. So one day I'm at work, and I am at a point where I am literally, have my head down on my desk because I'm in so much pain and discomfort. And I call my HMO and I say to them, I need to see a doctor today. And they tell me, well, the only doctor we could possibly get you into today is at a women's clinic. And at that point, I was in so much discomfort. I said, I don't care. I just need to see a doctor. And so I go to this women's clinic. I meet with this doctor. And it was the very first time in my journey that I had an actual dialogue with the doctor. And at the end of that appointment, I said to her, obviously you weren't planning on having a lot of men as patients, but if you will keep me, I would like to stay, because I feel like I've had a much better conversation with you than I have with any other doctors. And we still had the same issue where my blood pressure was very high, and we were having a very difficult time trying to get it under control. But, and this for me is the statement that came from this doctor that will stand out to me forever. She said, based on what I know about you, it doesn't make sense that we're having this hard of a time controlling your blood pressure. And I want you to see a nephrologist. So it's the based on what I know about you part that was completely different from anything I had experienced with the other doctors. So I went to a nephrologist, and after doing some simple tests initially, that the nephrologist told me that it looked like I was likely had the syndrome of FSGS. And so further tests went on, further monitoring, and at some point we did a biopsy, and she came back and she said, yes, you have FSGS. Now, what is common for most people is that when they discover that they have FSGS, that often, or excuse me, when they are diagnosed with FSGS, that within 2 years they are either on dialysis or looking for a transplant. And if you don't do anything, renal failure is renal failure is not something people survive if you don't take care of it properly. But for me, my experience was different than the average person. I was very fortunate. I never went on dialysis. We engaged in a lot of different drugs and therapies to try to maintain things and prolong the life of my kidney. And I actually made it until 2015. And that is when my nephrologist said to me, based on the numbers we're looking at, I would say you're probably 2 years away from dialysis. You really need to start telling people that you need a transplant. And so, in 2015, I first told a small group of people that I was very close to about my situation, because before this, most of my friends had no idea that I was dealing with any type of health condition or syndrome at all. So I did that. And then a year later, I went more public on Facebook and did a social media campaign and told people there that, what my need was and what my situation was. And I was very blessed that a good friend of mine from college donated a kidney to me in July of 2017. And everything has been going well. I didn't have any issues from the transplant. I've been very blessed, very fortunate. And I had told myself that after going through this, I wanted to do what I could to educate other people and prevent people from having that same negative experience that I had, because I seriously feel that if I had not found better doctors, that I don't know that my outcomes would have been as great. So that was my story. That is why I'm here. I'm about to introduce our two doctors to you. And if you have questions, we want you to send them to us in the private chat, where they're going to give us some information, and we will make sure that there is time for Q&A in the background. So thank you so much for everything that you're doing. Thank you so much for tuning in. And let me tell you a little bit about our experts. First, one of our experts is Dr. Jeffrey Kopp. He's a nephrologist, senior investigator at the National Institutes of Health. He studies FSGS, and his current work focuses on APOL1 genetic variants and causing FSGS in people with African ancestry. Our other speaker is Dr. Itunu Owoyemi. She's a board-certified nephrologist, kidney transplant, and onco-nephrologist. She's an assistant professor of medicine at Kansas University Medical Center in Kansas City. She is presently the assistant chair of the nephrology section of the National Medical Association. Her research interest includes improving clinical outcomes in patients with chronic kidney disease, including kidney transplant recipients. And with that, I want to turn things over to Dr. Owoyemi and welcome her this evening. Are you on mute, Doc?
Hello.
There we go.
Okay, thank you for the kind introduction. And thank you very much, Kevin, for your inspirational story and your kind introduction. And my name is Itunu Owoyemi. I'm an assistant professor at Kansas University Medical Center. I'd like to say a big thank you to NephCure for organizing this and Black Health Matters. And so this first session, we'll be learning about FSGS. But before then, I have no relevant disclosures. I'd like to walk us through chronic kidney disease and have a better and good overview of kidney disease. So our objectives for this session today is that at the end of this presentation, we can come away with a better understanding of kidney disease, know the red flags and or signs or symptoms pointing to FSGS, which means focal segmental glomerulosclerosis. We'll keep it as FSGS for this session. We would like you to be familiar with treatment options and clinical trials available to you, and be armed with resources where you can go to learn more. So let's talk about chronic kidney disease. Chronic kidney disease is defined as the presence of kidney damage or decreased kidney function for 3 or more months, irrespective of the cause. So if you have kidney damage or you have reduced kidney function lasting more than 3 months or more, it's termed as chronic kidney disease. So these are our two kidneys, and the kidneys are actually made up of filters. If you look through the kidneys, we have this filtration unit and we have this glomerulus. And each kidney has 1 million of these tiny little filters coming together and working synchronously to help the kidney function. So you can have kidney damage, where you would have protein or blood in your urine. You have structural abnormalities. You have glomerular disease, which is the abnormality in this filtration unit, which is one of the which FSGS is part of. So FSGS is a structural damage to this filter. We also have vascular disease, like blood vessels affecting the kidneys. We have tubulointerstitial disease, so part of the kidney filters being affected, and polycystic kidney disease with patients that have big, very big, abnormally big kidneys. So you can have chronic kidney disease from damage or decreased function. With decreased function, we measure the kidney function by using the glomerular filtration rate. So what is the rate of this filter? What is the rate of function? And we use this number, which I would like everyone to just note and keep at the back of your mind for your own personal GFR. So if it's less than 60 for more than 3 months, that's chronic kidney disease. Now you can have chronic kidney disease even if it is more than 60 and you have just damage. So you can either have damage or reduced kidney function. If you have reduced kidney function and you have no evidence of damage based on your labs or all these, then you have just chronic kidney disease. But if you have kidney damage and this number is still high, more than 60, 70, 80, 90, but you have any of these, then you still have chronic kidney disease. And so that's important because I will talk about that later on during this talk. So, who are the people that have chronic kidney disease? Actually, about 37 million US adults are estimated to have chronic kidney disease, and most are undiagnosed. 48% of people with chronic kidney disease who are not on dialysis are unaware of their diagnosis. And it's very interesting to know that Blacks are actually 3.4 times more likely than whites to have end-stage kidney disease requiring dialysis. So when you require dialysis, that means it's end-stage kidney disease. And this is a very interesting graph that shows the statistics by race of the prevalence of chronic kidney disease in the United States. And this is the percentage per year. So the blue bars indicate 2003 to 2006, the red 2007 to 2010, the gray 2011 to 2014, and the green 2015 to 2018. And so you can see the non-whites, the non-Hispanic, African American, Black race ethnicity, or Hispanic and Latinos. And this stands out to you. And if you look at the Blacks, the rate or the prevalence was actually worse in 2011 to 2014, but things are looking better from 2015 to 2018. So we use this chart to classify and stage chronic kidney disease. Remember, I had mentioned if you have chronic kidney disease, if your kidney function is less than, or your GFR is less than 60 for more than 3 months, you have chronic kidney disease. Or even if you have the higher numbers, this chart helps us to know when there are red flags, there are times to take some action or watch the protein in the urine, which is always abnormal because those filters filter away protein. You should never have protein in your urine. So you group them, the normal GFRs, you can still have FSA, and you can still have kidney disease if you have protein in your urine, and it goes down that line. And end stage kidney disease is when you require dialysis, which is at the bottom. So, what are the symptoms and signs of chronic kidney disease? I would first like you to look at this funny cartoon I found and really just illustrates what a lot of patients tell nephrologists or their healthcare providers. And the story goes, hey doc, for a long time I felt well, nothing, I looked okay. And suddenly I started having headaches, or my blood pressure was not well controlled, and I just didn't feel right at work, or I just didn't, things were not just going right. And then one day I just decided to go to the emergency room, and the doctor tells me you need dialysis because your kidneys have failed. Chronic kidney disease can be a silent killer disease. So how do you know you have chronic kidney disease? These labs are very important. This tells us the kidney function, the BUN and creatinine, how well the kidneys are excreting or letting these toxins out of your body. If these numbers are high, then it's something to look out for. Those are signs that you have chronic kidney disease. What about your urine? Some people say, oh, I just make urine and I'm about to flush the toilet and it feels like foamy, like beer or something. When you see foam in your urine, it indicates that there's protein, and that's abnormal. Some people have leg swelling and their legs just keep swelling and you're wondering what's going on. And sometimes usually it's both legs swelling. Some people's hands swell as well. And they say, my clothes no longer fit and it just feels like there's water underneath my skin. And some people just don't feel right, and most people just don't feel right. There's no clear sign. It's just, I don't feel right. I'm tired all the time. I just don't feel right. So those are signs and symptoms that can indicate that you have chronic kidney disease. Who should screen for chronic kidney disease? So if you have a history of diabetes, if you have a history of high blood pressure, family history of chronic kidney disease is very important as well. Some people that have families, brothers, sisters, moms, uncles on dialysis. I mean, before you even come to the clinic, you know what dialysis is all about. And you say, oh, when is my turn for dialysis? Family history of kidney disease is so important. And Dr. Kopp would tell us more and give us more insights about APOL1 and FSGS. What about sickle cell trait? That is very common amongst African American or Asian descent. Sickle cell disease. Now, if you are African or African origin, Hispanic origin, Aboriginal origin, or Asian origin, it's good to screen for chronic kidney disease because different races have particular diseases that are prevalent or more common in these races. If you have high blood pressure, complications in pregnancy after having a baby, and then you remember I told you, oh, we had to go and do a cesarean section, we had to deliver your baby because your blood pressures were just too high, and you had preeclampsia or eclampsia, and everything just went away after giving birth, after having the baby, and everyone is happy. You have to screen for chronic kidney disease because that's very common in people that have had issues with pregnancy and hypertension or high blood pressure. What about heart disease, cancer, kidney stones? You have to screen for chronic kidney disease, history of smoking, or recurrent urinary tract infection, hepatitis C, or HIV infection. And how do we really screen? We screen the urine and we screen the blood. And so this picture is a little fuzzy out, but we always look at the urine. And I always joke with my patients that if you show me your urine, I can tell you a lot about you. We check for sugar in the urine, check for protein in urine, check for blood in the urine. And those are pointers. Blood, protein in urine are abnormal, and they are pointers that you have chronic kidney disease. So when you go to your primary healthcare providers, pay attention to what the urine findings are. Do I have blood in the urine? Do I have protein in the urine? And then we check your blood work. When we do your blood work, we are checking for the function, the rate, the glomerular filtration rate, the creatinine and BUN that I showed earlier. So who should see a kidney doctor? Well, we define chronic kidney disease as a GFR of less than 60 when you look at the filtration. So when the kidney function is getting down to 45, you will need to see a nephrologist, because you have to start talking about how to slow the progression of the chronic kidney disease, and we have to monitor. We have to talk about transplantation when it's down below 30, and just give you education about chronic kidney disease and management as the kidney function declines. What about the hereditary kidney disease? If a family member has polycystic kidney disease or other hereditary family history of chronic kidney disease, it's so important that you see a nephrologist. What about the blood pressure? When the blood pressure medications just don't work, despite everything you have done. We saw that the picture before, and we heard about Kevin's story. Your normal blood pressure should be less than 130 over 80. So if you are consistently getting above that, you're on medications, you have tried everything possible, and it's still sky high, it's still higher than that, you need to see a nephrologist, just like Kevin did. What about inability to find the cause of the kidney disease? What exactly is causing the kidney disease? That's a good time to go to a nephrologist. And protein. There's a way we can check for your protein in the urine. If there's excess protein in the urine, you need to see the nephrologist. Even if your function, the GFR, like I mentioned earlier, is 90 or is a big number, and it says, oh, but it's not 60 yet, that protein means you have chronic kidney disease, and that is the time you need to see a nephrologist. So we learned about chronic kidney disease. How do you actually improve your kidney health and manage chronic kidney disease? There's ways to manage a chronic kidney disease as the disease progresses, but the things that we should note are to stay fit to reduce the blood pressure. We should monitor our blood pressures so that we know when things are just not working. Regular control of your blood sugar so you don't get diabetes. Healthy eating and weight checking. you know, don't smoke or get some help to quit. Maintain a healthy fluid intake and avoid over the counter pills, herbal supplements. And of course, get your kidney function checked out and always stay informed about chronic kidney disease. Ask about protein in your urine, blood in your urine, and your your BUN, your creatinine, your GFR. What is your kidney function? So be armed with information, and these ways you can improve your kidney health. So NephCure is a great resource. If you're found to have chronic kidney disease, you know a family member with chronic kidney disease, or you've been diagnosed with FSGS, which we are going to learn about shortly, go to NephCure and look at the resources available, look at the clinical trials, look at testimonials, and be armed with information. To hear about FSGS and APOL1, I would leave you with this last slide, which is from one of my mentors who is interested in learning about APOL1 FSGS, which we're going to learn about and hear about shortly. So if you know anyone or you're interested in learning about FSGS, you can check out his study where you'd get information about it. The information is also available on NephCure. And Dr. Kopp will come in now to let us know about FSGS, which is a type of chronic kidney disease, as I mentioned earlier, where the filter of the kidney is affected, and there are different types, different kinds, and the APOL1 is particular to people of sub-Saharan African ancestry. And so we'll hear more about that. Thank you for your attention.
Thank you, Dr. Owoyemi. And now we'll turn it over to Dr. Kopp.
Can you see my screen?
Yes, sir. There we go.
Excellent. So thank you so much for the invitation from NephCure and the fraternity and sorority. Thank you to Mr. Mott for that wonderful introduction and a very personal description of what it's like to have kidney disease. And to Dr. Owoyemi for graciously agreeing to go first and give the overview, which allows me to give you an update on this gene that she talked about called APOL1.
Hey, Doc, are you ready to share your screen?
I thought I did, so maybe I've done something wrong here. It's full screen for me. So let's see, remind me what I do to share.
I think you might need to exit the full screen.
Exit the full screen.
And then at the bottom, you should be able to share the screen.
There we go, sharing. Okay, thank you.
Yeah, just hit share screen. There you go.
Can you see the full screen now? Can you see my screen?
Nope, not yet.
It says I'm in the show. Okay, share. I've hit share. I'm in the show. Share my entire screen.
And so hit share and then select your presentation.
So can I just open up my presentation?
I believe so, yes.
Well, I did. So my presentation is open. Can you see it?
No, not yet, sir.
Sure, everyone can see.
Oh, so it's open the presentation and then hit share.
Well, then it occludes my screen by being entirely open. So I can't completely do that. So share screen. Share.
You know, Doc, I think we should get more to your subs. I know this is very technical, but I think we can just go into your conversation and then we'll try to get some of those slides back up.
Okay, I'd really like to get my slides up.
Okay, take your time, sir.
So tell me what I can do next.
You can, so you said open it and then hit share screen.
So open it in PowerPoint, or so when I open it in PowerPoint, it completely covers everything else up.
Okay.
So I've got the PowerPoint with the small images on the side. I hit share screen, but you're not seeing it. Is that right?
Right. So come back to the I guess the studio or whatever, StreamYard, and hit share screen there.
I am, and it's not taking it.
Okay.
Having issues.
That's all right.
Share. Any of that working?
It is not working, sir.
You're in the show. Everyone can see and hear you, so I guess they're seeing and hearing me. So it's on a window that says share your screen. At the bottom, there's cancel. I see you.
Yeah. So someone just said for you to get out of presentation mode by hitting escape.
I'm not in presentation mode. I'm just seeing my slides, but not yet in presentation mode.
Okay.
So you can see my slides. Is that right?
I cannot see. No, I can't see your slides.
Right. I'm going to try a cancel.
Okay.
And try it again. So it says in share screen, share screen, share.
Oh, she said they just saw it.
Okay. Can you see them now?
And hit share again.
All right, when I make it full screen, that goes away.
Okay.
So share. Can you see it now?
Yes, we can see it now.
Still?
Yes.
Okay, very good. Sorry for that
That's okay.
difficulty. Okay, so thank you very much to Kevin Mott and Dr. Owoyemi for that wonderful introduction. I'm now going to focus in whatever time I have remaining on telling you about this APOL1 gene that has been relatively recently identified as a major cause of FSGS. So you heard that African Americans are more likely to get chronic kidney disease, such that overall 13% of Americans are of African American descent, but about half of all dialysis patients are African American. And the lifetime risk for end-stage kidney disease is about 2% in whites and about 8% in blacks. And that increased risk among African Americans is about threefold overall. That is this 8% over about 2%, but it stretches across diabetes. So people with diabetes, if they're African American, are more likely to get kidney disease. So-called hypertension attributed kidney disease that we now understand is not necessarily due to poorly controlled hypertension, but in fact is due to variants in the gene we'll be talking about. And then various diseases of the glomerulus that Dr. Owoyemi introduced, the filtering units of the kidney, where the African American to European American ratio is about 5 for FSGS, which I'll be talking about, and AIDS nephropathy, now termed HIV nephropathy, also due to APOL1. So we're talking about glomeruli. What are they? Well, this is a picture of a kidney biopsy showing blood vessels that terminate in a globe of capillaries where the filtration occurs, allowing about 100 mLs of urine to 100 mLs of plasma to be filtered each minute to remove impurities. If we zoom in on this glomerulus, this ball of capillaries, again, coming off of this blood vessel, it looks like this in cross-section with little capillaries where blood cells would normally be present. They've fallen out in the process of generating this tissue image. The disease I'm talking about is a segmental scar, so it's segmental sclerosis, and it only involves some glomeruli, so it's focal segmental glomerulosclerosis. And this is a disease that some of you might have heard of in the context of 2 NBA basketball players, including, who was it? Blocking on his name right now. But
yeah, Alonzo Mourning and Sean Elliott.
Thank you for reminding me, who developed this disease. And there's a process where a glomerulus will begin to scar, get a segmental scar, and then move on to global sclerosis. There's some filtration of blood going through here. There's none going through here. And as patients approach end-stage kidney disease, most of their glomeruli will look like this. So the gene I'm talking about is apolipoprotein L1. You've heard of lipoproteins in the context of, for example, HDL cholesterol, the so-called good cholesterol, or LDL cholesterol. These are assemblages of lipoproteins that travel in our blood. So some of these have to do with the transport of lipids. It turns out that APOL1 is a hitchhiker whose job is to kill trypanosomes, the cause of African sleeping sickness. So APOL1 kills these organisms, and it does so by the organism taking up HDL particles, hoping to feast on the lipids present therein. But the APOL1 is a secret weapon that kills the trypanosome. Now, in the eternal battle between parasite and host, certain trypanosomes developed countermeasures that prevented the APOL1 from working, and these APOL1 genetic variants were selected for in sub-Saharan Africa to kill the resistant organisms. So in sum, every human on the planet, except 2 actually, have an intact APOL1 gene making APOL1 proteins, but these variants are only seen in people with sub-Saharan African ancestry. I sometimes say recent sub-Saharan ancestry because every human originated way back in time in sub-Saharan Africa, but it's people with relatively recent ancestry, less than 40,000 years ago, that carry these variants. So FSGS, focal segmental glomerulosclerosis, that you've heard about from both of us now, is a complicated disease, as you can see with this. My main point, as time is short, is to say that APOL1 variants are a very important part of it. So is primary FSGS. So is what is called post-adaptive FSGS, where the kidney is working too hard, either because there aren't enough kidney units, for example, somebody born prematurely, or there's obesity or huge increase in muscle mass, all of which make each unit work harder. And it turns out APOL1 contributes to this form of FSGS, to a form of FSGS that appears to be due to as yet fully unidentified plasma proteins that damage the kidney. Again, a complicated story. I won't dwell on it. But this summarizes that point that APOL1 related FSGS can look like primary FSGS, a form that can recur after kidney transplant, which is an important part for people to know about. It can be due to this role in the kidney working too hard, including prematurity. It can be due to HIV-associated kidney disease that we see much less now, that good antiviral therapy is available. But when we were seeing it, it was almost exclusively seen in people of sub-Saharan African ancestry, and certain drugs, particularly interferon, an injectable drug, which it turns out turns on APOL1. So these various types of APOL1 nephropathy stress that APOL1 variants confer a predisposition to kidney injury that can then cause different forms of FSGS. So how do we treat APOL1 FSGS? At the moment, exactly like we treat everybody else with FSGS. First of all, everybody with chronic kidney disease should be on a low-salt diet, should be taking a diuretic to potentiate the antiproteinuric effects of a low-sodium diet, to be on additional medicines, angiotensin receptor blockers, ACE inhibitors, and losing weight if obese. First-line therapy for all forms of primary FSGS, including APOL1, are steroids like prednisone and then additional immunosuppressants. On the other hand, if a patient in my clinic, I think, probably doesn't have primary FSGS, their serum albumin might be normal, their protein in the urine might be abnormal, but not as high as in primary, then I would say the same package that everybody with chronic kidney disease, including diabetic patients, should be on, but adding in particular a low-dose thiazide diuretic to potentiate the antiproteinuric effects of these other maneuvers. Sometimes you can really put your proteinuria way down almost to the normal range by an aggressive attack with these things. So this talk about genetic FSGS and APOL1 leads us into the topic for anybody with FSGS, or indeed anybody with kidney disease. Should I get genetic testing? And in some settings, the answer would be yes. So why test? It may provide an explanation as to why the kidney disease occurred. Some people like to have that information, certainly physicians do, and many patients would like an answer. Now, most genetic forms of FSGS don't respond to steroids, and that knowledge early on could save a patient from 3 or 4 months of taking a medication that has side effects but would not help most genetic forms of FSGS. There are over 50 genes that have variants associated with FSGS. Only a couple are steroid responsive. But there is another one that's worth knowing about. There are elements of our cells, the mitochondria, that are the powerhouses of the cell and generate the energy compound called ATP. Well, it turns out if you have a mitochondrial mutation and get FSGS because the podocyte cells are not working well, you may go to Costco, I don't mean to pick out one particular commercial entity, buy CoQ10 off the shelf, and that can help replace the defective CoQ10 or coenzyme Q10 that's not being made because of a genetic defect. So again, an excellent example why genetic testing can be a benefit. Also, genetic testing may prompt a search for extra-renal, that is, non-kidney functions, aspects that you wouldn't necessarily, or nephrologists wouldn't necessarily think about. This is not true of APOL1. the major disease associates with the kidney. There's some work going on to see if cardiovascular disease might be increased, but I think we don't know yet. Importantly, I should say that 50% of African Americans carry one or two variants of APOL1. Only about 13% carry two APOL1 copies. And even within that 13%, my guess is, and it's only an educated guess, is only about 20% of two APOL1 variants patients will get kidney disease. So is it worth testing? I would argue it is, because those individuals could be screened regularly. If they're lucky and go through life without getting kidney disease, great. But if it could be detected early, then in general, we believe that early treatment is better. And any of those out there with diabetes or diabetics in their family know that kidney screening is an important part of diabetic care. So the implications for other families is that it might explain or help predict kidney disease and help with the monitoring I just laid out if family members have the same thing. Well, are there any downsides to genetic testing? Well, yes, there are. It's possible that with genetic testing, you might discover kidney diseases that haven't appeared yet, or in the case of even if you knew you had APOL1, extrarenal kidney diseases. You might also find about rare diseases, this is not common, that have features that you might not know about. If you know that you have a genetic variant, there's guilt potentially about passing on a variant to your offspring. If other family members are tested, potentially this could disclose unexpected family relationships if the genetic inheritance doesn't line up. There is an important law to know about called the GINA law, the Genetic Non-Discrimination Law, that says the knowledge that is generated from genetic testing cannot be used to affect health insurance or your health care. But it can potentially be used by life insurance companies. I'm not saying that it necessarily is, but it's something one has to weigh in the balance of deciding to get genetic testing either for APOL1 or for other entities. And some of this is less an issue for APOL1, as most carriers of the APOL1 variants will not get kidney disease. So what are the arguments for APOL1 genetic testing? For somebody with FSGS, knowing that you have APOL1 variants as a cause would put you in a position to participate in two exciting clinical trials that are going on with therapies at the APOL1 molecule. So that's one reason. And for anybody, any African American, but particularly someone with a strong family history of kidney disease, there's a possibility that knowing that you have a high-risk status, again, about 13% of African Americans have two copies that put them at high risk, that might promote regular testing, that might lead to early detection, and that might lead to better outcomes. We know that this is the case in diabetes. We don't know yet that it is in the case of APOL1. So I can't promise that discovering this disease early is better than discovering it late, but I think eventually it will be shown that that's the case. But admittedly, before we go out and test and argue to everybody, one of the 42 million African Americans, that they need to be tested on a regular basis, there probably needs to be some careful studies that weighs the economic costs and possibly the psychological stress of this process against the benefits. So I think this is still an open question. That calculation will change if we know we have effective therapies for APOL1 nephropathy or APOL1 kidney disease. Then it will be like diabetic nephropathy, where we do feel that early screening, early detection, early therapy can slow or maybe even prevent progression to end-stage kidney disease. Now, you heard that FSGS can recur after kidney transplant. It's most common with primary FSGS, believed to be due to a circulating factor that is present in the system, and so it recurs after transplant. Typically, this comes back very early after transplant, at least the proteinuria comes back. It's less common with APOL1 FSGS, but it can happen. Very uncommon with this post-adaptive FSGS that I mentioned, for example, the premature baby or the very obese or hypermuscular person where the kidney is working too hard. Very rare with most forms of genetic FSGS. And there is therapy for recurrent FSGS. It involves removing the person's plasma, replacing it simultaneously with fresh plasma to try to get rid of the circulating factor. And it may lead to loss of kidney transplant function. So to come to the conclusion now, there are clinical trials emerging. So I'd like to review what the phases are. Phase 1 is the trial that has been studied. The drug has been studied in animal models, been shown to be safe in at least 2 species of animals, and is now ready to go into people, but we still don't know how safe it is in people. And therefore, the purposes of a phase 1 study in usually a small population of patients, typically about 20, 30, something like that. Is it safe at different doses? The doses that are believed from the animal models are likely to be effective ideally in the population that will receive it. So ideally, a phase 1 study of a drug for FSGS would involve recruiting FSGS patients, possibly at different stages of kidney disease. If safety hurdles are met, you go on to phase 2, and then you ask in a phase 2 study, if we give the drug to individuals for relatively short periods of time, 2 months, 6 months, something like that, probably at several different dose levels, does the drug work? And how do you define work? Well, in most of our kidney diseases, we follow protein in the urine, but ultimately we will want to know, does it keep people off dialysis, which is the job often of a phase 3 study, to put people on the drug for a period of time, perhaps many months, and then ideally a subgroup would receive drug for long enough that you know that you prevented dialysis or the need for transplant. And then phase 4 studies are, we don't say once it's approved, we can stop there. There's continued monitoring by the Food and Drug Administration to make sure that side effects, adverse events that weren't seen when maybe a few hundred patients were treated are now being seen that you're treating thousands or tens of thousands. So these drugs are really very carefully monitored to make sure they are truly safe and effective. So to close, APOL1 clinical trials are currently in progress, which many of us in this field are quite excited about. There is hope, as you see. I should have said perhaps that this drug, this APOL1 variant was first identified in 2010. So now, just over 10 years later, we have 2 drugs that target this molecule specifically. Both are actually injections. They're relatively small studies, 48 and 8 patients. The first one has a placebo control, the better design, because you'll know if the drug works. I'm sure if the Vertex drug shows promise in 8, they'll move on to a larger study. So it's an exciting time for us to be in this field, to see movement towards hopefully a cure. So there are other trials for native kidney disease, for native kidney FSGS, that is opposed to transplant. Again, an exciting thing for those of us in this field. Just to count up, there are 6 drugs currently in phase 1 studies. Again, small number of patients to look at safety. Phase 1 progressing to phase 2. And then sparsentan is moving towards a phase 3. So for many of us in this field that have had a relatively few number of drugs, some with quite significant toxicity to provide to our patients with FSGS, to see these new targeted drugs coming along is very exciting. So again, thank you to NephCure for sponsoring this. NephCure is an organization energized by patients that provides information at their website. Also, anybody has access to pretty much all of the published medical literature, or at least much of it. Much of it is freely available at PubMed. This was started by NIH about 10 or 15 years ago. Many of the articles can be downloaded free. And NephCure Kidney International, as well as NephCure, have sites. So again, thank you for your attention. I apologize for the difficulties getting started, and I would be happy to take questions.
All right, thank you, Dr. Kopp, and don't worry. You know, we much rather you be a nephrology expert than an IT expert. So you just it's fine.
I much prefer having that as well.
We're gonna get right into a couple. I got a really good question from someone who is a nurse. Her question is: if a Black patient comes to me and has high blood pressure that is hard to control with multiple medications, and then tells me her grandmother was on dialysis for many years and could never get a transplant, should I encourage my patient to get genetic screening and see a nephrologist?
I believe so. The number one thing is to, if available, to see a nephrologist, because I think we are trained to handle difficult controlled blood pressure, even outside the setting of kidney disease, people who have other causes of hypertension. So there are areas where nephrologists are scarce, but if that's possible. And then the APOL1 testing, I think, is something to have a dialogue about. At the moment, as I argued, there aren't strong changes that somebody would make in that setting. We would say, treat this aggressively. One argument I've made for testing to myself and to my patients is, if I know that you have APOL1 variants, then I know that you and I both know that you're at higher risk. I need to move quickly to control your blood pressure and proteinuria. You need to take the medicines. If they're not working, you need to tell me. We'll stop and find something that works better. So as the partnership is motivated to move speedily, because we know that some people will be on dialysis in 2 or 3 years after transplant, and we believe these therapies may help. But as I stressed, we don't currently have a randomized controlled trial that can assure us that the current therapies are going to help. I think they will. But I don't know that for an absolute fact.
Yeah. Dr. Owoyemi, so how do most of your patients come to you? Have they been referred by their physician, or have you gotten a lot of your patients that are coming to you because they requested to see a specialist?
Oh, that's a great question. So I'm a kidney transplant nephrologist. I see patients that come to me from their nephrologist looking for a kidney transplant, or trying to see if they are candidates for kidney transplants. And then we go back to their history and we find out about their parents, siblings, especially from the Black population. Oh, my cousin is on dialysis already. I started dialysis. So the family history is quite profound, and it's very important to note this when you talk to even your primary care provider. So there's a high index of suspicion, or there's just like Dr. Kopp reiterated, there's a faster pace to move along, because we are beginning to understand that there are genetic diseases that are identified and are being managed. Now, as a general nephrologist, most patients come to us through their general doctors, so through their primary care doctors. So as a patient, we've talked about dialoguing and having a conversation and a bond with your patient, with your doctors. It's very important to highlight these histories when you go to the hospital and say, okay, my blood pressures are not controlled, but this happens in my family. There's so many people on dialysis. Can you tell me what my kidney function is? Is there protein in my urine? Then we have those conversations, and then we can move along, getting to a nephrologist sooner than later.
Okay. I have another question here, and I'm just trying to clarify it.
Okay.
It's from a lady. For someone, my son has a rare disease, and I just checked his lab results, and his creatinine, it says, and here it says 64. I'm assuming that means 6.4.
Or perhaps it means BUN.
Okay, that would be the BUN. And over the last year, it's been as high as 74 and as low as 55, but he's never had high blood pressure. What should he be asking his doctor?
If that truly is the BUN, it's a very serious kidney disease. It can't be the creatinine with those numbers.
Right.
And he should clearly be evaluated for kidney disease, urinalysis, blood tests, and possibly a kidney biopsy, depending on the state of the kidney disease and whether or not he has a systemic disease that could explain it.
Mm-hmm.
Yeah, and someone asked if there's a registry of nephrologists that you can recommend to patients. I know at NephCure, on the NephCure site, we have something called Kidney Health Gateway, which can connect you to nephrologists in your area, particularly those that would have some experience with FSGS. But what other resources do you all recommend?
I would say NephCure and the NIDDK site. So I mentioned NIH. NIDDK is a unit of NIH, but if you were to Google NIH as a National Institutes of Health and kidney information, there's quite a good set of information there. Okay.
Dr. Kopp, when it comes to the genetic testing, and let me go back a little bit. I remember probably 10 or 12 years ago, asking my nephrologist, are there any clinical trials that I can get in? Because, we kind of were I always felt like we were playing medicinal roulette. seeing, does this work, does that work? There wasn't really a set plan. So I was interested in trying anything, but now that there are, clinical trials, and I'm hearing about genetic testing. So is genetic testing even helpful for somebody like me who is post-transplant?
I would say as long as you're transplant, let me think about it. I don't think there would be an argument for genetic testing. I may defer to Dr. Owoyemi to get her thoughts. What do you think?
So, with transplant, that's very interesting. Remember that you are getting another person's transplant, and this abnormal protein is in the kidney. So right now, we are looking for answers, and there's a clinical trial currently ongoing called the Apollo study that is looking at the kidney transplants, transplants gotten from Black donors to see whether when that kidney, when you put a kidney from a patient or a donor that's had APOL1, Fsgs or APOL1 gene variant, like Dr. Kopp had mentioned, do these kidneys function worse than patients that have not had this genetic abnormality? So that trial is currently ongoing. In a few years, we can answer that, which is a very important trial, because if you're a Black donor, you are classified as, having increased risk of, because your kidney being donated, we didn't know about the APOL1 until a decade ago. But if we can answer this, then we can classify who are the donors, or which donors have this gene abnormality and which donors do not have it, so that we can grade the quality of the kidney and give you better statistics on how well or how functional the kidney will be.
Could I take this question? Is high blood pressure a symptom or a cause?
Yes, sir. Go ahead.
So it is definitely a symptom of almost all chronic kidney diseases.
Right.
In some cases, it's a cause, particularly with what's called malignant hypertension. Blood pressures of 200 over 120, that damages the kidney. Many of us believe that chronic hypertension in a milder form rarely causes chronic kidney disease, but kidney disease can cause hypertension. And if somebody meaning the doctor, isn't evaluating for kidney disease, and that shows up after 5 years of hypertension, it's all too often said, oh, the hypertension damaged the kidney, but often it's the reverse.
Doc, that is actually one of the things that kind of got me motivated to volunteer after this time, because like I said, my progression was very slow. I went a very long time, and at a certain point I was wondering, how many African American men are strictly being treated for high blood pressure, and they should be getting treated for FSGS. And I'm not exactly sure what the difference would be in how the treatment, but I definitely think, there's kind of a stigma if you feel that, you've given yourself high blood pressure, and because you've given yourself high blood pressure, you've damaged your kidneys. And I think that's one of the stigmas that goes along that makes people kind of reluctant to reach out.
Two comments, if I could. One is, most hypertension is what's called essential hypertension. It has a genetic component. Diet does play a role. Obesity does play a role, or hypermuscularity. But having said all of that, you don't give yourself hypertension. And I think we need to get out of this blame situation and say people often have a genetic predisposition, and we need to tackle it without blame.
Right. Thank you. Thank you for that. Can you two read the next questions? It looks like a very important question. Do you want me to read it?
My son, is that it?
Yes, sir.
Yes. Let's see. Do you want to take it, Dr. Owoyemi, or me?
I can.
Yeah, I'll read it. My son is 12 and
Okay.
2.5 years post-transplant. His kidneys failed within 5 months of diagnosis in 2017, and he still has high doses of blood pressure meds and diuretics, as well as weekly plasmapheresis, albumin, and Lasix infusions. What should we be asking his doctor?
Oh, yeah. So sorry to hear about that. We have talked about FSGS, and there are different types of FSGS, and it's not uncommon for the primary FSGS to occur, And the one thing I can say is that you should go to NephCure.org and really read about the FSGS, read about the ones that are called post-transplant. And have discussions with your doctor, based on the information you find. There are support groups there. There are people that have been through this same thing. It's not uncommon for FSGS to reoccur in some situations after transplant. And constantly we are finding clinical trials that have been done in the past and that currently ongoing, that you may want to talk up to your nephrologist about getting your son to see whether he can participate in. And so there are so many resources out there to tailor to your son's present condition, and there's so many other people that have been through that can share testimonials. And so with that, you have a bank of questions, or you have a bank of resources that would really help you interact with your nephrologist and work together to see the next best steps for your son and his kidney disease management.
Okay, well, thank you. Well, I think this is going to be the last question, and I'll answer it. And it's: are there patient support groups that people can access if they have or care for a loved one with this rare form of CKD? And definitely, I would recommend going to NephCure.org. There's also the National Kidney Foundation, and also if you're currently seeing a doctor or a nephrologist, there probably are some resources at your hospital as well. But I think that's definitely a good place to look. If you're dealing with FSGS, there are Facebook groups for adults with FSGS. There are Facebook groups for people with children who are dealing with FSGS. Mm-hmm. So there are quite a few places, and also anybody who's tuned in is welcome to send me a message, and I'll help provide any information I can if you missed anything during the show.
Can I give one quick answer to a question? Registry of Nephrologists. There's not, but I think the thing to do is ask a doctor that you trust. Could be a primary care doctor, it could be a surgeon, could be a gynecologist. They will know nephrologists because every other physician works with nephrologists in one context or another, and they will have formed opinions, and they're the ones to go to about a good, caring nephrologist with the right skills for you.
Okay. I'll send this question to you, Dr. Kopp. Can you explain FSGS as it relates to the Savin factor?
Great question. So I mentioned different kinds of FSGS. So the primary FSGS is defined as that which comes back after transplant, because we believe there's a circulating factor. And even before transplant, we suspect that primary FSGS is what it is, because they often people have very heavy proteinuria and have a low serum albumin. The holy grail of this field, or one of several holy grails, is to find what that factor is. And Dr. Savin has an idea that it's a protein called cardiotrophin-like cytokine 1. In fact, we did some of the proteomic studies to identify CLC1 in the sample she was working on. Another group, Dr. Reiser in Chicago, thinks it's SUPAR, serum urokinase type plasminogen activator. I think the jury's still out, and it's possible there are 5 different molecules, and these are 2 of them. We don't have specific therapies yet, although I think Dr. Reiser is working on an absorbent column that will remove SUPAR from the blood. So this is a very active field, but it's still a fairly young, not fully mature field.
And Dr. Owoyemi, what would be your big takeaway or big message that you would want to end the meeting with today?
Okay, thank you very much for this insightful meeting. The take-home message is: arm yourself with information, know about your kidney function, know about your urine test, your blood test, and ask and collaborate with your physicians. Get to know when to get to a nephrologist and when to get help for your chronic kidney disease. And also tell your family about it. Talk about it. Talk about family history, because these things are important.
Right. And
sister.
And Dr. Kopp, I have a question for you. So if I was newly diagnosed today, what is the difference for me today as opposed to 10 years ago?
Wonderful question. I think we now better understand there are different kinds of FSGS, and they will take different therapies. In some people, diuretics, ACE inhibitors may be enough. In others, they need immunosuppression. And we have 2 drugs in clinical testing. They may work, they may not, but there will be new drugs after that. So I think there's great hope in this field as both the nephrology field and the pharmaceutical field and patients and organizations are paying attention, so that the story we heard earlier about the person who, I think it was you actually, who said, well, I was just told there was a little bit of protein in my urine, not to worry about it. Hopefully that's happening less and less and less, in part because of the organizations like NephCure that are getting out the word protein in the urine should be an alarm to pursue.
Okay. Well, thank you very much. Obviously I've been in this journey in one way or another for 19 years, and this was one of the most informative discussions I've ever heard. So I really appreciate you, and I really appreciate that you use your talents to help people like me. And you do more than you know. Let me tell you that.
So thank you so much for organizing it. I'll say if questions didn't get answered, you'll send them on to one of us, and we'll make sure to get answers back.
Yes.
Good. Thank you for the audience for being so participatory.
Right. And thank you, everyone. Thank you to Black Health Matters. Thank you to NephCure.org, Travere Therapeutics, Kappa Alpha Psi Healthy Kappas, Healthy Communities. We're doing 2 more of these. We look forward to talking to you again, and we hope we've given you a little bit of information to make life a little easier. You all take care, and God bless.
Thank you all.
Thank you all.